I'm again delighted to welcome you to today's session in the seminar series on ethical issues in organ transplantation. I'm rather sad that we're sort of coming to an end soon. We have 3 or 4 more sessions. It's been a wonderful program, and today we're delighted that Dr. Sandy Feng from the University of California at San Francisco is able to join us. Dr. Feng is director of the Abdominal Transplant Fellowship Program and a professor of surgery at UCSF. As a Marshall Scholar, Dr. Feng earned a PhD in molecular biology at Cambridge University before starting medical school at Stanford. She then completed her general surgical residency at the Brigham and Women's Hospital, which was followed by a fellowship training in molecular biology at the Whitehead Institute and training in transplant surgery at UCSF. Her numerous leadership positions include serving as a counselor for the American Society of Transplant Surgeons, as deputy editor of the journal, the American Journal of Transplantation, and as chair of the Kidney Pancreas Advisory Committee for the American Society of Transplantation. Dr. Feng has organized and participated in many national conferences around the issue of transplant. Her research focuses on transplant immunology, especially on organ tolerance, and today her topic is this topic? This topic.
That's the one.
Optional tolerance in children after liver transplantation. Fact, fiction, or folly? I can't wait to hear it. Please join me in welcoming Sandy.
It's such a pleasure to be here. I was just talking to Dr. Siegler about dinner last night. We went to a very sophisticated and educational restaurant. We took a tour of the kitchen after the meal, and the food was just, prepared with such precision and care. They basically were plating all the food using these amazing forceps. And I turned to Dr. Thistlethwaite and Dr. Melissa, and I said, whoa, I could use those in my operating room. They're much more delicate than what I get. So it's just been a real pleasure. So I'm going to kind of take you through sort of a research program that's organically developed that I've been involved with, which is to basically look for operational tolerance in children after liver transplantation. So operational tolerance, if we were to define it, means that you basically can have an organ working normally in a transplant recipient in the absence of immunosuppressive medications. We call it operational because we don't really formally test whether the patient is indeed tolerant to the donor. We don't put a skin graft on. We're just saying, hey, look, this kid is on no medications. The liver continues to work well, and therefore this person appears to be tolerant. I'm going to describe a small pilot trial that I did, which started, 7 or 8 years ago, and then a larger trial that I just started about 6 to 8 months ago, and then a trial that's in the planning stages, which will probably start in 2014. So you'll get to kind of see how the program has grown, and we can maybe discuss later if this is fact, fiction, or folly at the end. So I was actually asked to organize a course for the AASLD-ILTS transplant course back, I don't know when this was, maybe 2010. And the title was Long-Term Outcomes of Adult and Pediatric Liver Transplantation. And the kinds of talks that we had, which we thought were the main challenges to good long-term outcomes, were talks about chronic kidney disease, hypertension and cardiovascular risk factors, diabetes, obesity, and the metabolic syndrome, as well as malignancy. And as I think everybody in this room knows, these are all complications of immunosuppression. So if we think about these topics in the pediatric liver transplant population, I think you'll see that there are problems, but they are much more attenuated compared to the adult population. This is a study that was published about 6 or 7 years ago, taking a look at 117 pediatric liver transplant recipients and looking at the quality of the kidney function based on a GFR that was actually measured and not calculated. They also assessed blood pressure measurements at the 1-year post-transplant visit. And what they found was that the mean GFR was 95, but that approximately a third of the patients had clearly low GFRs of 70 and below. And so this tells us that children undergoing liver transplants are at risk for chronic kidney disease. Now, this population was the transplants, some of them occurred predominantly in the cyclosporin era, some of them occurred in the Prograf era, tacrolimus era, and so I think there is general consensus, and I'll show you some other data, that the Prograf tacrolimus era has been more favorable, kinder to the kidneys than the cyclosporin era. But clearly there is the potential for chronic kidney disease. If you looked at blood pressure profiles for children about a year post-transplant, and you look at people who had systolic or diastolic blood pressures greater than the 95th percentile for the age, you also include the people who are on antihypertensives, and you would you come up with the fact that at 1 year post-transplant, 53% of pediatric liver transplant recipients actually meet a definition of hypertension if you choose to include all of these considerations. Now, post-transplant diabetes is a little bit less of a problem, and you can see this study, which was published about 5-6 years ago in biliary atresia patients, showed that approximately 6.7% had post-transplant diabetes within 30 days, and which continued. But I think perhaps the biggest, broadest view of how children are doing after liver transplant is this very recent paper using the SPLIT database, which is the Studies in Pediatric Liver Transplantation database, and looking at the prevalence of renal dysfunction and cardiovascular risk factors in 10-year survivors. So obviously these are the people who we think are doing really well because they've already survived 10 years after their liver transplant. 9% had a calculated GFR less than 90, 20% had hyperlipidemia, 26% had triglyceridemia, and only 1% had diabetes, although 9%, kind of comparable to the previous paper, had diabetes more than 30 days post-transplant. So this is kind of a broad view of what's going on in children and may be related to immunosuppressive medications. What about malignancy? This is a paper that came out in 2004. I'm sorry, the citation's a little bit too low. And this specifically looks at pediatric organ transplant recipients. And in the conclusion, it basically says skin cancers develop in early adulthood at an average age of 27 years. So we have to wait a really long time, but it's likely that they are coming. It's just we haven't gotten there yet. So I think these are some of the motivations to think about maybe stopping or minimizing immunosuppression in children. But I think you'll also agree, if you think about these types of endpoints, it's going to be very, very difficult to design trials that show that reducing immunosuppression or stopping it is beneficial. Are we going to follow children until they're 27 years old for their skin cancer to show up? Are we going to wait for the first heart attack? Are we going to look at, chronic kidney disease? These are all very, very long-term problems. And so I think the first point I want to make is doing trials in this area, and, I've come to the ethics mecca here. I'm already on shaky ground because the benefit side of the equation is pretty darn shaky. So what do we know about tolerance after liver transplantation? So way back in 1969, Sir Roy Cohn published this paper because he noticed that pigs could accept liver allografts but not other solid organ transplants in the absence of immunosuppression. I guess this tells us we're not that far off from a pig. So here's just a summary. It's probably not completely comprehensive, but this gives you a flavor of what's gone on in the adult world. I call these withdrawal experiences because they're really not trials. There weren't strict inclusion-exclusion criteria. Everybody didn't do the same thing. These are a conglomeration of patients, some of whom stopped drugs themselves. Basically, they were non-compliant. Some of them, physicians stopped drugs because they developed a severe contraindication to ongoing immunosuppression, such as post-transplant lymphoproliferative disorder. And some of them were electively withdrawn. So this is a hodgepodge. But the basic message is that people have been trying to do this for quite some time, since 1994, and in total in the literature there's somewhere around 300, 400, and the general rate of success has been about 18%. 53% have developed acute rejection. Some of these were clinically diagnosed as opposed to biopsy proven. But of course, this doesn't add up to 100%, so some of them are just kind of not accounted for. But I do want to call your attention to this column, which are sort of the bad things that can happen. Deaths and retransplant attributed to chronic rejection. And the percentage here is low, but far from negligible. Now, obviously, some of these studies are pretty early when chronic rejection was a much bigger problem in the liver transplant world, but still suffice it to say, bad things can happen if you stop your medications. Now, in the pediatric world, there's really two broad experiences. The Pittsburgh experience, again, this is a motley group of patients stopping for various reasons. These are deceased donor transplants, and so you have about a third of them off of drugs, 50% still kind of going very slowly, or this isn't clearly reported. 14% or 9 developed acute rejection in an effort to get them off of medications, but there were no episodes of chronic rejection. The Kyoto experience is very different. This denominator represents, at that time, all of the pediatric liver transplant recipients that they follow at their center. And they basically set up a protocol where if you're more than 2 years post-transplant and you're doing well according to a bunch of criteria, they were just going to take you off of drug gradually. So this is more protocolized, whereas this is sort of the hodgepodge experience. And what they found was that 15% with a very big denominator, right? Obviously these denominators are much smaller. They're very highly selected. This is a less selected population. 15% of those were able to come off of drugs. There was one patient with chronic rejection, but this was rescued by triple therapy. There were no deaths. And so I think that this is the view we have of the pediatric experiences. So to summarize this whole business of withdrawing immunosuppression, low likelihood of success, high risk of acute rejection, albeit the feeling is that the acute rejection is readily reversed without permanent damage to the liver allograft. There's a low but non-negligible risk of really bad outcomes. And of course, as I emphasize, uncertain benefit. Maybe intuitive, but no convincing data. So this is, I think, what I mean by I'm on shaky ground. In 2011 at AASLD, there was actually a debate, hot topic debate on tolerance. This is the pro withdrawal, and Avi Shaked took the con side, and he summarized that patient benefit is not detectable, inducible, or reproducible. So let's go back into around 2005 or so when I started this pilot trial of immunosuppression withdrawal, which was funded by the Immunotolerance Network. This is a single-arm, 3-center pilot trial of 20 patients at UCSF Children's Hospital, Children's Memorial, and Morgan Stanley Children's Hospital of New York. And we published this a little over a year ago in JAMA. And so why did we target children? Or maybe that's a very bad word to use, but why did we choose to do this trial in children? Well, first of all, children have, in theory, a very long life ahead of them. Therefore, they have a longer burden of immunosuppression. we wondered if there might be a higher likelihood of success, perhaps partly based on the data that I showed you in terms of comparing the adults and the kids, but also a typical practice in pediatric liver transplantation is you basically get people stabilized on medications, and after about a year or so post-transplant, you never change them. Now, the vast majority of children undergoing liver transplants are infants and toddlers. So if after a year post-transplant you're not changing their medications and they're growing, they're sort of naturally kind of weaning on their own. And so we thought, gee, maybe we could take advantage of that kind of thing that they've been doing, and this might lead to a higher likelihood of success. Another consideration is the available of parental living donor liver transplants. If we dived into the deceased donor or the adult population, back then, adult to adult living donor transplant was highly experimental. We didn't have any donor tissue, and if you don't have donor tissue, you didn't have any chance of doing any science, but also perhaps the living donor setting with a parent with one HLA, one haplotype matching and less ischemic injury may also be more favorable in terms of success. So we decided to design a trial focused on children. And here are the brave 20 canaries that went into the coal mine here. In summary, basically, they were half of a year of age at transplant, evenly divided between males and females. 16 of the 20 had biliary atresia as the indication for transplantation. And note, they were enrolled in the trial 8.5 years of age, so approximately 8 years after the transplant. You can also see in the background here the kinds of doses of immunosuppression they were on. Patient number 2, who's 9 years old, was on 0.35 twice a day of Prograf. Now, just to let you know, maybe the parents are crazy and the kids aren't crazy, because the regimen for withdrawing the immunosuppression, I'll show you shortly, requires that these children get blood tests done every 2 weeks for a year. Most of these kids are getting blood tests done every 2 to 3 months. So these parents want to have their kids do this trial to get them off of 0.5 milligram of Prograf a day, 0.7 milligrams of Prograf a day, and they're willing to participate in this very intense monitoring scheme. So this is the inclusion-exclusion criteria. Again, we focused on living donor. The donor had to be a parent. We couldn't have unfavorable etiologies of liver disease. They had to be more than 4 years post-transplant with normal liver tests on just a single drug with excellent kidney function. Of course, consent, and have no autoantibodies and an Ishak fibrosis score of less than 2. An Ishak fibrosis score of less than 2 is a pretty darn pristine graph, especially if you're thinking that this is 5-10 years post-transplant. So the way that this is, I didn't give you a list of the inclusion and exclusion criteria because I just wanted to show you. I'm really digging in the weeds here. I'm really cherry picking for the best possible patients with the greatest possible physiologic, sociologic, and liver reserve. And so this is another question that came up with the NIAID DSMB is why don't we target kids who have poor kidney function? Why don't we? And I think that can be debated as to what is the right population to do something where the benefit is very uncertain and there obviously is risk. Oops. So this is the withdrawal protocol. There's no reason to go into it except to say that this happens stepwise. We combine the twice daily dosing to once daily dosing, and then we start dropping off days of the week. So this module, which 18 of the patients were traversing, took 36 weeks or 9 months. And then for an additional 3 months post-transplant, they were still continuing to get the every other week laboratory tests. So this is the outcome. Of the 20 participants, 12 were able to come off of medications. This figure in terms of the x-axis is not updated, but the shortest at this point is now 53.3 months, and the longest is 74 months. So this child, as of February 28th, 6+ years ago has not taken any immunosuppressive medications. So this has been a very durable outcome. All of these children have remained off of medications, even though they've been sick, they've been hospitalized, they've had gastroenteritis, they've had cholangitis, they've had, everything that 8, 10, 12-year-old kids get. These are the 8 children who did not succeed in withdrawing from their immunosuppression. One patient whose phenotype we therefore don't really know was only withdrawing for about 2 weeks, and we discovered an inclusion-exclusion criteria violation, so the withdrawal was just aborted. 4 children developed allograft dysfunction, and I'll show you more about this, as they were withdrawing during the blue portion of the line. And then 3 patients developed allograft rejection shortly after stopping all medications, including 2 that were diagnosed on the protocol biopsy that was done 4 to 8 weeks after the last dose of medication. So I really want to focus on the 7 children. I'm not going to discuss that child who violated the inclusion-exclusion criteria 2 weeks into the trial, because there's not much we can say about that child. But let me show you what happened to the 7 children who had a problem. So here you see them listed. This is a start date when their liver tests started to escalate above the baseline. This is the peak ALT and GGT. These are the 2 sentinel tests that we were using. You can see most of them have elevated ALT and GGT, but this single patient, for example, had a very normal GGT but had an elevated ALT. 2 people have no labs because these were the people who were diagnosed with a problem because of a protocol biopsy. Their labs were stone cold normal at that time. Now, what was the central reading of the pathology? Well, only 2 patients met the criteria, the Banff criteria for rejection. The rest were all rated as indeterminate, and this patient is really kind of confusing because shortly after this episode, like within a week of starting treatment for rejection, he was identified as having a biliary stricture, so it's not really clear what this was. Now, not all of the local pathology readings were rejection either, but suffice it to say that all these children got treated, and I would hazard a guess that except for perhaps his biliary stricture, all of these were rejection. We just are not used to diagnosing rejection when we're monitoring the immunosuppression every 2 weeks in this very, very, very late setting. I think the biology of the rejection is very different. The tempo of rejection is very different. And so I'm not surprised that they don't meet technical Banff definition, but I actually agree with the clinician's judgment to treat them because, these kids are perfectly fine. You start taking down their drugs, the liver tests go up. I mean, it just doesn't take a lot of brains to figure out that rejection is 1, 2, and 3 on the diagnosis, except perhaps for this person. So how were they treated? Well, 3 of them received steroids. 1 received IV because this was moderate, and they just used their standard of care treatment protocol. This was not dictated by the study protocol. This was dictated by standard of care. And these were short courses of corticosteroids. Some children went from wherever they were in their withdrawal back to the baseline, the dose that they were on when they started. Some children had escalation. They went above where they started, but you can see, and then the episode ended at some point in time, and I'm happy to say all of these children have resolved the rejection. It's hard to say when things stopped for these 2 kids because it's hard to even know when exactly it started. So next I want to talk about, can we find any predictors at the baseline when they're all queuing up, entering the study? What data or specimens did we collect that might be able to sort who's going to succeed and who's going to fail? So if we look at various clinical or demographic characteristics, two emerge. The time between the transplant and study entry was significantly different, and the absence of any inflammation on the baseline biopsy. You might add, wow, why did you even allow people with any inflammation to withdraw from immunosuppression? Were you just kind of crazy? Well, this inflammation that they had was actually just the presence of some lymphocytic cells within the graft. There was no evidence of ductulitis, no evidence of tissue damage. So yes, they were allowed to withdraw, and it turns out that absence of inflammation as opposed to even mild or moderate inflammation was favorable for withdrawal. Nothing else. The age was not, gender, whether they were on Prograf or cyclosporin, whether they had a history of rejection, what their baseline liver test was. I should actually tell you, one of the 20 patients is actually an ABO incompatible patient. So that doesn't seem, and he's one of the tolerant children. If we look at HLA, really nothing emerged, but please remember that there's only 12 and 7. And so if you look down here, and I'll show you more about sensitization, you can see that in general, the tolerant patients had lower prevalence of sensitization and lower prevalence of DSA. On the other hand, you can see that 5 out of the 12 or 4 out of the 12 did have alloantibodies or DSA and were tolerant. So while it is a risk factor, it's certainly not 100% in one way or the other. So here's some of the data related to alloantibodies and C4D score. Again, this is all baseline at the time that they started the study. And I'll show you longitudinal data in a minute, but this is the baseline. So if you look at the DSA negative, which are the filled-in circles, and you look at the DSA positive, which are the open circles, and the y-axis is C4D score of the frozen section assessment of the screening liver biopsy, you can clearly see that there's a difference and that there are more DSA negative patients who are tolerant, and the C4D score was higher in the non-tolerant patients. So this is just what C4D staining on frozen liver tissue looks like. Here's a portal tract. Here's the central vein. Green is C4D, red is an endothelial cell marker, and you can see that this is co-localization in the portal tract, and you can see very, very bright, beautiful staining. Well, beautiful, maybe not beautiful, but very clear staining around the central vein. And so the C4D score is a sum of the various endothelial and vascular compartments all summed together into one score. There was also a difference in the MHC class 2 staining, again, for the baseline liver biopsy, less in the tolerant, more in the non-tolerant. You may not be able to see it because it's the green staining, but here it is graphically. Again, successful patients had lower MHC class 2 staining, whereas the non-successful people had more staining. So I want to shift from predictors at baseline. We're very limited because we only have 20 children in the trial. We're not going to come up with any robust predictors, but we're pretty happy that we had a few hints. I want to now look at the tolerant patients longitudinally, because obviously a huge concern is, are we harming the liver if we have these children just hanging out on no medications? Is there some occult process going on? So first, let me just give you a little background. This is data regarding what does the long-term liver look like in pediatric liver transplant recipients. So there are 3 studies, and they're from the UK, either Netherlands or Belgium, sort of Central Europe and the United States, which show that as time passes, the pediatric liver allografts have increasing fibrosis. So you can see all the bars going up, all the darker colors going up. And so this is a pretty clear message. Now, these are children who are on immunosuppression, mind you, but is taking them off of immunosuppression going to accelerate this process? Now, the Kyoto group, who again have this very unique approach to just weaning immunosuppression, They've also added some fuel to the fire because they show that at baseline, of course, everybody looks perfect. Those who are on maintenance immunosuppression have generally less fibrosis than those who are tolerant and are off of immunosuppression. Now, part of the problem is that this is a cross-sectional study. They just took a bunch of biopsies and said, okay, who's on drugs, who's not on drugs, and you can see that there are a lot of differences between those who are tolerant and those who are on maintenance immunosuppression, including the time between this index biopsy and transplant. And I just showed you data that we know that fibrosis increases with time after transplant. So maybe the difference is just because the non-tolerant patients on maintenance immunosuppression are 4.5 years post-transplant, whereas the tolerant patients are on average 10 years post-transplant. Maybe this doesn't have anything to do with anything, it's just a marker of time. What they also did is they also reintroduced immunosuppression in 11 patients that they were worried about. And what they demonstrated was that for many, there was a 1 Ishak stage drop in fibrosis between no immunosuppression and restarting immunosuppression. And a single patient went from 2 all the way down to 0. But this is a little bit deceptive because some of these biopsies are only 4 months apart and some of them are 54 months apart. They're not all done at the same time under the same circumstances. And we all know that for a liver biopsy, 1 Ishak score is actually within the error of the assessment. And so this isn't strongly convincing data that restarting immunosuppression has had an impact. But it's there and needs to be considered. Finally, very recently in 2012, there's a paper also from the Japanese, the Kyoto group, about the triad, fibrosis and donor-specific antibodies and how they're all related. So here what you can see is, again, increasing fibrosis stage to the right, and DSA positive patients are in the open columns. So you can see that with more fibrosis, there are many more patients who have donor-specific alloantibody. And this also basically says the same. These are the DSA positive patients, and you can see that these people have more C4D staining. So this is the relationship of these 3 factors: fibrosis, donor-specific alloantibody, and C4D staining. So more DSA, more C4D, more fibrosis. They seem to be making this connection. So how do our 12 brave patients who are out there without medications doing on these 3 characteristics? I'm going to be presenting this at the ATC, so this is just a horrible slide that I had to use for the abstract because you got to get all the information on one slide. So let me just briefly take you through it. Each plot is one of the patients. So there's 12 patients. You can see their patient numbers. The numbers above are the summed titers of the DSA. So if they have 1 and it's 22K, that's what's listed. If they have 10Ks, then I put 20K. So it's the sum of the MFIs, okay? Now there's 4 sets of bars. And the bars represent when they came into the study, right when they stopped their medications, 2 years off of medications, 3 years into the study, or 4 years off of medications, 5 years into the study. And the first bar, the dark bars, are fibrosis, central and portal, and the hatched bars are inflammation. I've only shown you a scale of 0 to 3. But because these are stacked up, the y-axis should really go up to 6, but then that would leave a lot of white space. So I shortened it to 3 so they look more dramatic. But suffice it to say that there's no clear pattern. There's no clear increase in fibrosis. There's no clear increase in inflammation. And there's no clear increase in class 2 DSA MFI for these 12 patients who are off of medications. What about the C4D score? Well, unfortunately, the frozen tissue can be very tricky. So we unfortunately don't have C4D staining for 5 of the 12 patients. So here are 7 patients. And what you can see is that there does appear to be an increase in the C4D score in several of the patients, but it's not associated necessarily with donor-specific alloantibodies. So there's a disconnect. Here's a big increase in DSA, but no change in C4D score. And so again, we don't have any clear evidence that there's progression of anything in these 12 patients. The last piece of data I'm going to share with you, I only got last week, and we are very excited about this, is that basically the tolerant patients, their alloantibodies are not IgG subclass subtype 3. They're 2 or 4. 3 has been implicated as much more pathogenic, much stronger binding and complement, whereas the children that actually failed immunosuppression had IgG subtype 3. So I think that we need to get more sophisticated than saying DSA. We need to say, oh, there's probably no good alloantibody, but I think we also know that not all alloantibodies are equally bad. And it may be that the patients who are tolerant actually have the more benign flavors of alloantibody, whereas the patients who are non-tolerant have the more destructive forms. So a story yet to evolve. So how do I conclude where we are with this? We have 60% achieved the primary endpoint, but this is really incredibly highly selected. There were no serious adverse events. Rejection episodes did not meet SAE criteria. So there was no really bad chronic rejection, deterioration of allograft histology, graft loss, or death. Tolerable tolerance thus far has been durable. And we did identify some features on the biopsy in the interval between transplant and entering the trial that did predict successful withdrawal. So on the basis of that, I'm going to tell you about the 2 new trials. I'll be very brief about IWITH, and then I'll go into triple. So IWITH is just a bigger withdrawal trial. Pretty much. It's 12 centers, 100 patients. Our goals are to define the prevalence. It's hard to define the prevalence of anything when you only have 20. Determine the safety, again, the same comment. But more importantly, I think we want to derive a biomarker of operational tolerance. You know, we've talked a lot about the fact that the benefit side of the equation is pretty shaky. So what we need to do in order to make this reasonable is to lower the risk side of the equation. So, you know, when we started this trial, our consent form told patients there's a 20% chance of success. And the flip side of that coin, there's an 80% chance of failure. And failure basically means something going on with your liver, allograft dysfunction, rejection, chronic, you know, all those other things. But if we could tell patients, gee, you know, you have a 60% chance or you have an 80% chance, then we can mitigate the risk side so that this shaky benefit isn't, you know, as much of a concern in terms of the whole equipoise of this decision. So I think that with 100 patients, we're going to have a much better chance of looking for a biomarker of tolerance. Now, obviously, the biomarker of tolerance is going to be really valuable if it works in a population where the prevalence is relatively low. If the types of patients that we enrolled, if 60% were really the prevalence of tolerance, then, you know, the biomarker can make things a little bit better because maybe you could say 80%. But if we could use the biomarker in a population where the prevalence of tolerance might only be 20% and find that, you know, a subgroup of those are much more likely than the others, then that's where the biomarker can really help, I think. So for this population, we're getting a little bit more bold. We're going to include deceased donors, but we're going to also limit it to young children in order to have a slightly more homogeneous population. And much of the same stuff is all there. So I want to just tell you where we are. We've biopsied about 65 patients. We have biopsy results on about 50 of them. 33, or about 2/3 or a little less, are eligible to withdraw. 17 failed the screening biopsy. And so we're about 1/3 enrolled. The trial actually opened about 7, 8 months ago. So we're really doing well. We hope to be fully enrolled by the end of this year, and we're marching along. We have about 22 patients that have started withdrawal, and thus far we've had 3 rejection episodes. But some children are about 8 months into the withdrawal algorithm. So some children, the early ones, are almost off of their medications.
Did you use the predictors of tolerance?
No.
Study
No.
time on immunosuppression?
No.
No.
We thought that these were clues, but we didn't. If you look at it, even children who are 4 to 8 years post had about a 50%, 40, 50%. So it wasn't dramatic, but there was a trend. So just one word about biomarkers, and then I'm going to talk about the triple trial, which I think is more conceptually interesting and even more controversial. So how do we find biomarkers? Well, you're trying to find what is different between tolerant and non-tolerant. But you need the biomarker to work here when everybody's taking their medications. But you need to know the phenotype in order to say this versus that. And so most biomarkers are done, are derived with this puddle of patients whose phenotype is already known. But of course, one of the big problems is there's one huge difference between these people. These people are not taking drugs, and these people are taking drugs. So you could be spending your $1 million on microarrays and basically coming up with a biomarker of a person's taking drugs. So this is one of the biggest challenges. And what we've found in the peripheral blood is that the signals that are identified are much, much clearer at this point in time and very, very attenuated at this point in time. They're still there, but they're so attenuated that differences in how the specimens are prepared from center to center and shipping and all those things wipe out many of the differences. There's more promising work happening in the tissue itself, but I just wanted to kind of point out this biomarker challenge. We also, in theory, don't know when this biomarker emerges. Is it even present before you start, the gauntlet of withdrawal? And there's also the concern that this phenotype is very rare. There may be multiple mechanisms to achieve the tolerant phenotype, and the mechanisms might change over time. There may be people who are tolerant a year or two post-transplant through one mechanism, whereas those who are not tolerant until 8 to 10 years post-transplant, they may have achieved it through a different mechanism. And if there are different mechanisms, then maybe there isn't one biomarker. So I think that this developing biomarkers sounds great, but is not so simple. Okay, so the last part of my talk is to talk about the triple trial. This is actually funded as part of the new C-TOT-C grant. And so we've got a sketch of a protocol, so we're hoping to get this opened up in another 6 to 9 months. It's an open label phase 1/2 multi-center trial. Multi-center is a little bit glamorous. It's only 2 centers to determine the safety and efficacy of a single escalating dose of autologous polyclonal Tregs to induce tolerance in non-tolerant pediatric liver transplant recipients. So the basic idea is we're going to find patients, we're going to take them through withdrawal, what I just showed you, to identify the tolerant versus the non-tolerant. The tolerant children will just be followed. We're going to, pat them on the back. The non-tolerant children are going to be the focus of our attention. We're going to isolate their own Tregs, expand them in the laboratory, give them back to the children, many, many more, and try withdrawal again. So if anybody thinks that I'm going to need anti-acid medications, I think I probably will. So this is the general thing. Now, when we recruit patients, we're not going to want a population that's 60% successful, right? Because then all we're going to do is end up with these, which are not our primary area of interest. We really need to find these people. So we're going to shift the time frame so that we're not going to wait until they're more than 4 years post-transplant. We're going to shift the time frame because we know time post-transplant, or we think we know, and it's been shown in adults as well, so we know a little bit more than what I've just described, that time is a factor. So we're going to try to target a 20% success rate population as best as we can guess. And that was the success rate that allowed us to do the pilot trial. So I'm saying, well, that's the success rate that's going to allow us to do this trial. Because then 20% will be tolerant, but 80% will fall into this bucket, which is really the zone of interest. So I'm not going to talk about Treg biology, but suffice it to say, these are now the favorite agents for operational tolerance, and there's a lot of data in animals to indicate that they work with multiple mechanisms in terms of regulating the immune response. The Tregs that we're going to be getting are going to be the natural Tregs that are going to be isolated from the peripheral blood of the child. And what it is that we propose to do is that we're going to isolate the Tregs, and then they're basically CD4 positive, CD127 low or negative, and very, very enriched P3 positive. And we're going to put them through this culturing protocol where they're going to be expanded by stimulation with anti-CD3 and anti-CD28 beads. There's going to be a second exposure to the beads on day 9. There's going to be IL-2 feeding, and then at day 14, the expanded Tregs are ready, and the release assays and the functional analysis will be performed to characterize the product. So what do we know about how we can make this product? Well, this just shows some actually early data. We're much more uniform by this point, but you can see that we can expand Tregs anywhere from 300 to 3,000 fold. We can get 5 billion Tregs from a single unit of blood, and the product maintains the phenotype that went in, and they are highly suppressive. So here's their FOXP3, here's their ability to suppress. Each colored bar is a different polyclonal Treg preparation, so you can see that they're very good at suppression. And another thing I should mention is that these cells are basically demethylated in the region of the FOXP3 gene that tells us that they're bona fide, active, working Tregs. So this product is being currently tested in a non-transplant patient population, type 1 diabetes. So these are generally adults 18 to 45 with a recent diagnosis of type 1 diabetes. This is a 2-center study, so we will have had experience. We've already had experience shipping this product across the country because that also introduced, we also need to be able to get the cells from the patient if we're having a 2-center study, because UCSF makes the cells, so we already have established that experience in this trial. And this particular trial is very comparable in that it's a single dose escalating dose trial of 5, 40, 320, and 2,600 million Tregs given to type 1, recent type 1 diabetics. Oh, okay, sorry, I knew So at this point, 3 of the 4 cohorts are enrolled. So I'm going to just mention the safety data for 3 cohorts. There's a 3-month pause between each cohort. So we're in the pause between cohort 3 and cohort 4. The infusions have all been well tolerated without any reactions. There's been no evidence of any increased number, severity, persistence, or duration of infections as a sign of generalized over-immunosuppression. There have been 34 adverse events in a total of 8 patients. There were 3, 3, and 4 patients, so So there's 11. 8 of those 11 have had 34 adverse events. There have been none that have met SAE criteria. In terms of the grading, 28 mild, 3 moderate, and 3 severe. The 3 severe were considered unrelated to the study drug, and they were vomiting, hypoglycemia, and dizziness. So thus far, this product appears to have a reasonable track record in a small number of young adults with type 1 diabetes. So what do we propose to do for this trial? Our primary endpoint is a safety endpoint. How many patients getting Tregs have adverse events that reflect either immune activation if the cells we give are contaminated with T effector cells, or the Treg phenotype is not stable after infusion and the regulatory cell phenotype changes to an effector cell phenotype, or on the other hand, how many patients show any evidence of over-immunosuppression because they develop some sort of infection. For example, we're going to be checking patients and being sure they don't have circulating EBV at the time, because we don't want to give children Tregs when they have EBV or any type of infection in the system, because these are polyclonal, they don't have specificity, and they can result in over or non-specific immunosuppression. Our secondary endpoints, again, starting with safety, is infusion reactions, infections within 6 months, acute rejection, frequency, timing, and severity. There are some efficacy endpoints. I think one of the elements of the design of this trial is that we're going to start out with people who failed withdrawal. So we know that these are non-tolerant patients. We're not giving Tregs to all comers. We're only giving Tregs, exposing the risk of Tregs to the people who, quote unquote, may have something to gain in the terms of being able to successfully come off of medications. So we are going to try to figure out if the non-tolerant participants are converted to being tolerant based on a normal liver test and a biopsy 1 year after stopping immunosuppression. We're going to also be able to do individual comparisons. So we're going to be able to look at a patient pre-Tregs, how do they perform as we were withdrawing immunosuppression, versus post-Tregs, how do they perform? Does it take longer for them to reject? Do they reject at a later point in time on less medications? Is there a sense that we've gotten them further towards the spectrum towards tolerance? Mechanistic endpoints, it's always good to get money to do a lot of science. So biomarkers of tolerance, magnitude and duration of increase in circulating Tregs following the alloantibody response, histologic correlates of tolerance, and comparisons of leukocyte populations, global gene expression, cytokine, A, B, C, D, and E. We're just going to try to figure out what are these Tregs doing, how long are they around, and what are they doing. So one detailed slide on just the trial design. So again, starting with the non-tolerant population, we propose to treat and stabilize them over a 6 to 12 month period, and we're going to declare some patients ineligible to continue. If you fail immunosuppression as soon as we start trying, we're not going to do this, because we don't know how potent this product is. This might be a surrogate for someone who's primed to reject. So if you fail very quickly on the first attempt, we're not going to try. If you have bad rejection, either based on histology or treatment, we're not going to allow you to do the Treg portion. But if you are okay, then if you get to a point where you're on the same dose of immunosuppression that you started the original withdrawal on, or lower, and you're stable for 8 weeks, then we're going to give you a little baby dose of Tregs. 5 million per kilogram is pretty modest. It's probably not going to be enough, but we're going to do an assay to see if there's a quote-unquote adequate Treg increase, adequate defined down here. And if there is, we're going to allow you to withdraw. But if there isn't, then If there is, we're going to allow this patient to withdraw, and all of the patients will only get this dose and proceed to withdrawal. So there'll be an initial small cohort to try to make this assessment. But if this initial small cohort does not reach adequacy, then we're going to do a Treg increase, and we're going to use 5 times that dose. And we're not going to do an adequacy test because now we're basically at the limit of our production capability. And then we're going to try withdrawal. So our power calculation from an efficacy perspective, this is what we kind of think. We're going to start out with maybe 30 patients, and some of them are not going to have biopsy that allow them to do anything. But this will be low because this is an earlier post-transplant population. 20% are tolerant, 80% are non-tolerant. Among these that are non-tolerant, for some reason or another, 7 of them are not going to do the Treg thing. They don't want to do it. They rejected too early. The rejection was severe. So we're going to have 13 patients who might be eligible for Tregs. And if we then end up with 12 patients who end up undergoing withdrawal, then we're going to figure out how many of these non-tolerant patients are still non-tolerant versus tolerant. And as you can see, because our numbers are pretty small, we'd have to really be hitting a home run to have any statistical power. On the other hand, I would argue that if 4 of these kids who were non-tolerant are now tolerant, I think that's a weak but intriguing signal. So these are the ugly numbers, but they are what they are. And this is just a diagram of the mechanistic assays. Obviously, the mechanistic assays and any insight they might provide as to what the Tregs are doing are going to make the clinical trial much more informative for the future populations. So I think I'm at the end. I have no idea what time it is, but my conclusions are to say that so far, we think that a significant portion of long-term pediatric liver transplant recipients may be operationally tolerant. This biomarker would really improve the risk-benefit assessment of this withdrawal. Ex vivo expansion of autologous Tregs may have sufficient potency to accelerate operational tolerance. As a surgeon, I'm not very patient. So acceleration of this thing so that we don't have to wait 10 years. If we could wait 2, 3, or 5 years would be much more appealing. And ultimately, I think we still have an unanswered question that we really do need to pay some clear attention to, is what is the impact of withdrawal on allograft histology? Right now, we don't see any danger signals. I think we've done what we can do to monitor the allografts. The original 12 tolerant patients are now in a long-term extension follow-up, so we will have biopsies on them for even 8 to 10 years on no drug if they stay that way. So I think the verdict is out, but it's really amazing because some of these kids that are in my original trial, they're high school, I get prom pictures, they're going to college, and it's very rewarding indeed for me. So this doesn't happen without a very large village, and these are only a few of the people who are important in getting the work done. This is the group at UCSF who helps with all of the patient work. Jeff Bluestone, who of course is an alumnus of this institution, is the sugar daddy of Tregs, and Kizzy Tong, who's his postdoc, heads our lab. She's now an associate professor, and she is the translational guru and the connection between the clinical and the manufacturing. Kalpana runs my clinical trial unit, all my work as well as for the entire division, and of course my boss, who's very supportive. Special collaborators, all of the PIs in the upcoming trials, and the Immunotolerance Network, as well as ROW, which is the Data Coordinating Center, and my program officers and great helpers at both NIAID and DK. So thank you so much for listening.
Sandy, thanks so much. I'll get to you in a second, Dick. I got a question or two. Given that this is an ethics talk, what...
See, I stay away from things I don't know a lot about.
What number of patients that would have lost their graft in this trial would you have said that it is unethical to continue?
You know, we've debated and discussed this a bazillion times because, you know, as you come up with ideas for stopping rules, you're trying to say, well, what if we see one? What if we see... It's hard to know. We basically said that one is enough to halt and look very carefully. One death, you know, even a car accident, we have to halt and make an assessment. Because the numbers are so small and the confidence intervals are so large. It's not that nobody ever loses a graft. On the other hand, probably it would be pretty shocking for a person who's eligible to enter the trial to lose a graft. So as far as I'm concerned, one is enough to really just say we really have to think 5 times about this.
So then to get into a little bit of the design of the trials, it seems to me that not necessarily in your primary endpoint, but in a lot of your secondary endpoints of fibrosis and biomarkers, et cetera, a control group would really be good. Okay? So how have you thought about that, and why don't you describe
why don't we have one?
Control groups?
Yeah. So in the 100-patient withdrawal trial, we talked about doing a control group. So a control group could be a group of patients that are not, you randomize. You withdraw versus you don't withdraw, and then you look for change. The concern is that we have a lot of data about progression of fibrosis over time in a cross-sectional, relatively non-selected population. But if you have a group of people who have really beautiful livers 5 to 8 years post-transplant, frankly, a 4 to 5 year time frame is very short. And based on the pilot trial data, we know that the people off of drug are not progressing. So how do you even power this control group? What would you expect? We didn't even know what would be the expected rate of progression for this population on standard immunosuppression was going to be. The other group you could compare it to is you could compare it to the kids who reject and then go back on.
Right.
So then the question is, well, was it the rejection? If there is no difference, then had you done nothing? Had you just kept them on? Maybe they would have been better. So the rejection was bad, coming off of drug is bad, and these two groups end up the same. So you really need the pristine control group that you're not touching, in which case you would have had to randomize. And then these kids would have been exposed to liver biopsies, which are currently not standard of care at most centers. They actually aren't. There's only one center out of the 12 which does protocol liver biopsies. And so it was then, what do? If you are unlikely to find anything out, you don't have good a priori information to make these calculations, it was hard. And so we debated this back and forth, and we ended up not having a control group.
And then the final question for me before we get to Dick and others. So in your triple trial, when you've already stated that time is a significant predictor of tolerance, how do you know that it's not just the extra year you're waiting versus your Tregs?
Well, I think that in the adult literature, there's a very steep increase over a long period of time. So I think most people would say that 6 months to a year is probably not sufficient time. On the other hand, you could say that perhaps this little rejection episode could have stimulated some, retitration of immune response. It's not the perfect thing, but we decided to do it in this manner because we could get a potential efficacy signal in a small number of patients and minimize the exposure of the agent to a smaller group of children. So I agree, there's always a lot of potential ifs, ands, or buts, but it's a compromise.
So I had two questions about the triple trial. The first is based on sort of the accepted paradigm of risky research or any research in children.
Speak up a little bit so the people in the back.
Okay,
That just goes to that.
Okay, excuse me. So the first that has to do with the accepted paradigm of research in children, which is animals, adults, and then children. And we can talk, and I don't want to talk especially about whatever appropriate animal models, but there may be some. But your triple trial could be done in adults. There's no way that it has to be done in children. So why are you bypassing adults when the only evidence for the safety of the agent is in a single phase 1 trial that's not yet even completed?
In adults.
In adults. So that it seems to me you're going totally outside the accepted paradigm for ethically acceptable research in children.
Well, I think that, I can't argue with that. We could do this. We could do this in adults.
It's not,
but
sure it can be, but why did you skip that step?
Well, because it was a funding mechanism to get the trial done. It's a bad answer, but, there was a funding mechanism to get the trial
especially
done.
talk about ethics.
Yeah. But, and I think that we are doing a Treg trial in adults, but it's a completely different game. It's an even riskier Treg product. It's a donor alloreactive specific product, which has a lot, much higher risk. So we thought that based on the animal data, the general safety of the polyclonal Treg product, the fact that we will have phase 1 data in a population of relatively younger people as opposed to older people, we just took the plunge.
But the diabetic trial is in adults, right?
Yes, it's 18 to 45,
Yeah.
but most of them
Yes.
are on the younger side of young. They're not 6 years old. No.
Yeah. Okay.
No.
So my second question is about controls in this trial, because you're assuming that someone who is rejected and attempting withdrawal and receives this product may become tolerant. But there's also the possibility that someone has rejected during withdrawal and has been retreated, has developed their own Tregs, such that
That's
when you
what I
withdraw
meant.
again,
Yes, that's what
then
we
and
could've-
so
yeah.
so you don't have that control.
But we can use
Many-
some of the biology, the assays, we can look for Treg. I mean, we can do as best as we can to try to determine in a longitudinal manner and to characterize these immune responses in a longitudinal manner through the mechanistic. So,
Because many patients now who have an initial rejection do incredibly well on minimal immunosuppression long term. In your own trial, some of the patients who you entered had actually had early rejections and yet still went on to be tolerant.
Right.
So I'm not sure having a rejection says necessarily that if you see 4 people who are tolerant when you give Tregs, that you wouldn't have seen 4 if you didn't.
So I think that the strongest argument I can make, which I think is actually a pretty good one, so you better listen, is the Avi-Shaked trial. There's several people who have attempted a second withdrawal and have not been successful. So the Avi-Shaked trial is in the same sort of time frame. There are 2-3 years post-transplant. They've attempted withdrawal. They've been stabilized, and they've attempted withdrawal again, and then they failed. So that suggests that the episode of rejection doesn't, in and of itself, then, in a short time frame, make you tolerant. When I showed you the rejection, these were the typical early within the first year, and now we're 8 years later. So that's a completely different scenario. So there's no way to eliminate all of these possibilities. There's no way to do a mouse experiment, but we're hoping that this will at least be safe, which are the primary endpoints, and will give us some glimmer of information to allow us to do other things. This is just kind of a pyramid.
So I've got another question. We've known since the early days of pediatric liver transplantation that all comers, 20 to 30%, are tolerant over time. Why is this protocol any different than just saying you have an enriched, because of your selection criteria, you have an enriched population that is now 60% instead of 30%?
Well, I don't think that we know that all comers are 20%. I mean, I think the adult withdrawal experiences, I think, many of those people have PTLD, which I think puts them into a different sort of biological bucket. So I don't actually think that all comers, we have 20%. We also know from the adults that at less than 6 years post-transplant, tolerance in adults is very low. If you get transplanted at less than 50 years of age and you're less than 6 years post-transplant, there's like a 0% chance of tolerance, quote unquote, according to the Europeans. So it's very low. If you're transplanted at more than 50 years of age and you are 6 years to 10 years post-transplant, then it's higher. So I first would question the 20%. But suffice it to say, I don't know it's 60%. It could be 35% because the confidence intervals are incredibly wide.
0 to 100, right?
Correct. So it's probably not quite that. It probably doesn't go all the way down to 0. But I think that that's the purpose of the second trial. We have 100. We're going to at least have a confidence interval of about a total of about 20%, because we pitched it at 35% success rate. We ratcheted it down because we're including deceased donors and, we've loosened some criteria. And so we're saying 35%, and if we hit 35%, the confidence interval is 25 to 45. So that's as tight as we can get it with 100 patients.
So thank you for a very interesting talk. But your last answer actually reiterates Dr. Thistlethwaite's point, which is if you know that people under 50 who have been less than 6 years out have a 0 chance of being tolerant, that is the perfect population for your triple study and not the kids. So now I'm going to ask my question, which is...
Just one comment about that is we actually are concerned that the polyclonal Treg product may have limited potency. So we may not be able to take a group that is 0 and make them anything. So I think we have to think of this as a gradation. People are more over here or more over here. And the polyclonal Treg product may only be able to make a modest shift. So the people who are just too far from whatever this tolerance state is are just never going to get there. So we need people that are kind of close. I mean, we're just trying to nudge the envelope backward towards the time of transplant.
Except that you've never tested the Tregs in pediatrics. So you're actually doing two different things, which, as a person who only sat on an IRB for 17 years and then developed some sanity, my question then comes to you is thinking about how this study could be approved. Because since you don't know if Tregs are actually beneficial, you now have a high-risk study without necessarily even clear benefit. Did you undergo a 407 review, or was this approved at local IRBs?
We don't even have a protocol yet. We have a grant, and this is, right, it's funded. We're writing the protocol. We don't have a IRB, a full IRB
So what are you going to
approval.
do when your IRB says this has to be done in adults? Because that's what our IRB would do.
Figure it out when we get there, They didn't want us ever to do the first trial to begin with. And we managed to, convince the NIAID DSMB to do that trial. And I think Dick remembers the whole...
And Mark is the head of the ethics committee.
Oh, there you go. Now it's all revealed.
Sandy.
This is like, taking the masks off.
Sandy, I thought very hard about the first study, as did the committee.
Yeah, and I had to fight very hard for it.
You did.
I fought.
And we approved it. But I must say that I'm sensitive to Dick's remarks and Leonie's about this triple study. I would add one more concern. No, I mean, if you've not gone to IRBs yet, at least hear them in advance so you can anticipate them. But I think Dick and Laney raised good points. My concern has to do with your deliberate effort in this study to select for people who will be non-tolerant. I mean, that's almost built in. That is to say, you're looking for the 80% non-tolerant.
Well, we don't want 30% because then, we're just doing more of the first trial.
Based on, but then the take-home lessons that you presented to us from the first study that you did was that the longer time in immunosuppression, particularly around 10 years, was better. The absence of any inflammation on entry sort of looked better, and a lower prevalence of sensitization looked better. Now, I did ask you briefly during your talk whether you're going to build those three factors into the recruitment process or whether you're deliberately not going to build them in.
I think for this, I think we want to build them in because what we want to do is we want to shift the time to an earlier time point. We don't want to deal with unfavorable alloantibodies. We're just focused on the time. So because we're shifting the time post-transplant, we want everything else to be optimized. So we already have, for the larger withdrawal trial, much more stringent entry criteria relative to the inflammation.
You do? Good.
Yes. The first trial was local reads in order to allow withdrawal or not. The big trial is central reads, and we have a list. We look at portal inflammation, perivenular inflammation, portal fibrosis, perivenular fibrosis. We have tightened the screening biopsy criteria. It's not just inflammation, it's a bunch of other things, but we did not do anything with the alloantibodies as a criteria. Because again, half of the children who had alloantibodies were successful.
Correct.
87% of those without were successful, but 50% of those with were successful. So it's hard to say you want to rule those kids out. On the other hand, we might be ready to get rid of the IgG subtype 3 children. So we are going to, we don't want to be working on all these things. We want favorable biopsies. We want good alloantibody profile, or at least not bad ones, but we want to shift the time. We don't want to be dealing 6, 8, 10 years. We're going to probably say less than 3 years post-transplant and recruit a patient that's more like 3 to 6 years post-transplant. So it's not a dramatic shift, but it's a slight downward move.
Yeah, so, I guess my point is that, yes, if you recruit the patients 3 to 6 years post-transplant, it'll give you a better chance to get the 80% rejection. Whereas if you recruited patients who were 10 years post-transplant, it would be more difficult. You'd have a lower number based on your own data.
Surrogate consent. It's hard to justify.
Am I not saying it clearly?
Yeah, you are.
You are. I like to say on Sandy's behalf that the goal of minimizing overall immunosuppression, in other words, not waiting 10 years, is very beneficial to the patient. Right. And so that if you're looking at what you're trying to achieve, minimizing exposure to immunosuppression is probably a very important thing. That's me.
Is that okay? As long as it's not me, I'm okay. So I mean, I think that, there's just a lot of discussion can be had.
Yeah, I'd like to mention that there is published data on T-Rex in children from Poland already in diabetes care, right?
Yeah,
there is a 1 year follow-up, so the study is going on.
Type 1
new onset of type 1 diabetics in children. Yes, it's a safety study.
But there was actually a mild hint of efficacy, although Jeff
right. I mean,
sold.
it's just 10 patients. It's hard to say, but it's safe.
Its own study shows a mild hint of efficacy as well, right? No one's actually lost insulin.
Correct, but it's so early that.
Yes, I know.
Yeah.
No, there's a trial in Poland.
It's not his OKT3 this time. All right, looks like we've got the bus came. So.